I'm getting echo-alia here. Our January 24th meeting will begin right now. Thank you. And shall we, I will offer an invocation. Lord, we thank you so much for getting us through this week with the crazy weather and all. And I would pray that you give us wisdom as we make decisions pertaining to folks that are receiving our services. Give us clarity and unity, and we just ask that we keep your name in mind and that you are honored and glorified as the result of what we accomplish. We pray in the name of Jesus. Amen.
Amen.
At this time, I'd like us all to stand, and Tom is going to lead us in the Pledge of Allegiance.
I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Okay, we have our first item is to take a look quickly at our mission and vision statement. And these are our consent items, and nothing new there. Okay, so we're going to go this time to our public comment. This is one of two times where you're able to come and express what's on your heart and mind, and you'll have 3 minutes, and we will have another opportunity towards the end of the meeting. So at this time, if you'd come forward. Here's an old friend, Stephen.
Good morning.
Morning.
Yeah, Stephen Rockman. It's good to be back. And Miss Gretchen being here. And Kira, today is her birthday.
Oh,
Painful reminder that life is short.
Hmm.
You know, not one of us here has a guarantee being here tomorrow.
yeah.
With that sobering thought in mind, I make this comment to suggest a guardianship service and support. I have a son with autism, and if you have a child with IDD, you're familiar with transitions. We parents are aging, and we face our own transition. And hopefully you have an estate plan. And in that estate plan, you may name a guardian. I think the CMH could be a partner in that plan. For example, CMH could offer a guardianship training program. By illustration, I think it's a way to make a difference. I do self-date. Before I can hire a CLS worker to have to take online training in recipient rights, bloodborne pathogens, and first aid, I conceive the board strategizing to create a visionary online training program for future guardians. I think that will fit into your mandate to provide strategic and visionary leadership to the CMH. The probate court once had a guardianship training video. Maybe that could be found and built on to meet the needs of CMH consumers. And additionally, I think it's important for standby guardians to start building relationships now with their supports coordinators. I think that collaboration together with a guardianship training program could prove to be an invaluable service and support. So I thank you for your consideration of this comment. It feels odd being on the other side. But God bless.
Thank you.
Barbara Lee Van Horsen from the City of Grand Haven and the Momentum Center. And first, I want to just echo and support Steve Rockman's suggestion for guardianship support. Also, as a parent of an adult child who's IDD and mentally ill, those kind of resources would be really invaluable. So I hope you'll take that into consideration. I also want to invite you to our next town hall. We're beginning a town hall series on mental health. And we're beginning with mental health and politics, talking both about the negative effect that the political environment can have on our mental well-being and also the positive effects that can be achieved by getting involved in political advocacy, as all of you have done, deciding to be part of a system. So looking at both the negatives and positives, our speakers include Dr. James Dumeroff. We have several professors from Hope College, Dr. Deidre Johnston, Pat Rowling, Marisha Doshi, and Dr. Fred Johnson, and Lupita Reyes, who's a counselor at Lars. It'll be next Thursday, January 30th at 6 o'clock at our facility in Grand Haven, 401 North 7th Street, the former Rendezvous Restaurant. Everybody is welcome. It is a community conversation. We do ask that you register just so that we have an idea of how many people to expect, but that's not required. So if you forget to register, please still come to the conversation. And then in March, we have already begun the lineup for the second in the series, which will be mental health and religion. And again, the positive and the negative that can come in those relationships. So I hope you'll be part of those conversations because we're all part of the community. Thank you.
Thank you, Barb. Anyone else? Public comment? Mhm.
Rosalie Austin, City of Holland. That sounds like an interesting meeting. I wonder if that can be live stream, virtual participation to be accessible to the community because a lot of people cannot get out in this weather or drive or the time or
Mhm.
to participate. But I agree with Stephen that we need to educate and inform parents, especially our aging parents, of their options and what's available as far as services and how to meet those needs.
Thank you, Rosalie. Nobody on the phone? Okay. Okay, at this time, our public comment has ended and we're gonna do a little switching here. If you look at number 10, under new business on our agenda, we want to, at this time, we need to come up with a chairperson for this meeting. And I am going to open the floor to accept nominations. So at this time, are there any nominations from our board as to a new board chair? Go ahead and speak up. Yeah, oh, I'm sorry. Yes,
I would like to nominate Sylvia Rhodey.
pardon me?
Sylvia?
Okay, we have one nomination of Sylvia. Do we have any other nominations from,
I'd like to nominate Mr. Byrd.
okay, we have Sylvia, we have Miss Bird, okay, so that's two. So again, I'm gonna ask for any further nominations from the group.
I'd like to nominate Dave Parnan.
Okay, so we have a third person, Dave Parnan, and I'll ask one more time, do we have any further nominations from our board? Okay, so I guess the best way to do this is show of hands right now. Roll call.
Could we actually discuss this for a second?
Sorry, I can't,
So could we discuss this for a second first before we go to a vote?
okay.
Okay, I guess I would just like to say that I appreciate the nomination, but I will be supporting Tom Byrd, so I'd like to withdraw my name.
Okay, good. And that's a good prompt for myself. My term ends at the March meeting of this year, so I would like to withdraw my name from, I appreciate that, you suggested it, but I'll pull my name off also. So that leaves one candidate that I can see.
Can we just, I appreciate both of you. I just, in the last couple months, just getting to know Mr. Byrd, I just appreciate what he brings to the table and his background. And so that's why I nominated Mr. Byrd.
Yep.
But you both are great.
I completely agree. I have full confidence in Tom Byrd leading this
Yes,
board.
Tom has the mind and the heart to do the job. So, okay, so I'm gonna have a motion. Can somebody please give a motion for our next board chair?
I would move that we would elect Tom Byrd to be the next chairperson of CMH.
Okay, we have a motion.
Support.
Do we have a second?
Support.
Support. We have a motion and support. Any further discussion? All in favor of the motion, please say aye. Aye. Any opposed? Motion carried. So at this point, we will turn the meeting over to Tom. Thank you.
Thank you all for your support. I pray that I will live up to your expectations. And thank you, David, for stepping in. For those who are unfamiliar with our bylaws, David, as vice chair, assumed the responsibilities of chair upon the resignation of our previous chair, Gretchen. And we appreciate your willingness to step in and handle the transition. And as I understand the bylaws, I have been just now elected to fill the remainder of Gretchen's term through April 1st. And then the board will have a new election of officers at that point for the next year. The next item is the consent agenda. We have a suggested motion for approval of the agenda and minutes for today.
Second.
Any discussion on the minutes? Could we have a roll call vote?
Ms. Bunce? Ms. Hovind?
Yes.
Ms. Wenzel? Yes. Mr. Savage?
Yep.
Mr. Davis?
Yes.
Mr. Byrd?
Yes.
Supposed to be last, sorry about that. Ms. Rhodey?
Yes.
Mr. Kleinens?
Yes.
Harnan?
Yes.
Great. Next item is the Chief Executive Officer's report. Michael?
First, I'd like to welcome our new board member, Bob Davis, to the CMH board. We also have Peg Faulkner, who couldn't make it today, joining. And so welcome. I had an opportunity to meet with you briefly this week, give you a brief overview of some things and looking forward to continuing your orientation. And I appreciate your long history of service as a service provider for folks with mental illness and developmental disabilities and substance. You've done it all. And I knew of you when I worked in Hope Network,
Right.
when you were in Kent County doing a lot of work. And we are very blessed to have Bob Davis on our board. He brings both a viewpoint of what's good for the folks, for families, for consumers, and clinical excellence. So I believe we're very fortunate to have you join us. I welcome our new chair. Thank you for stepping in. One thing that's not in my report, that's a big elephant in the community, is what's going on with our CMH board and county appointments. And there is discussion at the county level about examining the history of our board appointments, making sure we've been following statutes correctly in terms of terms. I'm also aware that the county commissioners on the upcoming Tuesday agenda has CMH board appointments listed. Legal counsel's also given a written opinion to county commissioners about how, based on an analysis that we've done with them, about our board process selection and terms. I can't disclose the content of that. It's privileged at this point, but I know it will be addressed this week. So as your CEO, my job is to keep my eye on the ball make sure we're doing the work of CMH and assist in any way with the county commissioners, legal counsel, and CMH board to help resolve any confusion or who should be on our board. I also want to make public record that I don't make the decision. I work for you. I don't work for the county commissioners. I work for the CMH board. But this CEO will give any assistance that the board, the commissioner chair, the commissioners need to the county administrator, this board, and any information I can provide to provide clarity on this issue. And I hope that this gets resolved quickly and that Ottawa County can continue to focus what we've been doing for the last several months on this board, of having a board that's been coming together, I think, quite nicely, solving the issues at hand, and ensuring we have appropriate representation as required by the Mental Health Code. So if you're in the public and you're reading the Board of Commissioner agenda and you just, what did we just do here today? It doesn't affect the chair status at all that we just did. It's just how are county commissioners appointed to this board? What are the terms is really the issue. And Anna Bednarik and Amanda went back to all of our records for 2 decades to see how we've been doing this. We've been a board since 1969. A lot of those records are gone about how the appointments have gone and the timeframes. So I will keep the CMH board updated as much as I can as this issue gets continually discussed. I intend to attend the county commissioner meeting on Tuesday. Unfortunately, it's during the time I was going to be somewhere else at a town hall. So we'll see what we can do, because I was looking forward to attending the town hall at Compassion Heart Ministry. I think you have over 90 families already, Donna, signed up for that.
Yeah, it's a housing topic and it's a
Yeah.
hot topic,
Yeah.
obviously. And
So I intend to do that, but I just wanted to inform the board. I've been sending you tons of emails. I don't expect you to kind of read every one and go, but I will keep you abreast of all of this activity and release information as I can. But loud and clear, I'm going to be a full and active participant in assisting the county in any way to help resolve this. But I will not put the needs of the CMH consumers over anything. So I think there were some emails this morning and I was reminding one of our commissioners, well, I don't make the ultimate decision. And they're like, no kidding, but thank you for all the work you're doing. So just wanted to make sure the board was aware of this issue. I feel it will be resolved next week. And I look forward to moving forward with the work that we're doing on the board. The other thing I'll be doing is instituting a new practice. It's not in your written report, that anytime we have a board member that leaves service, we've had a couple, that at the next board meeting that we do formal resolutions of thanks. So in February, I'll be bringing forward formal resolutions of all the CMH board members that have stepped down, resigned, or terms have ended over the last year. And I want this to be our practice. Immediately following when there's a change on the board, to recognize the work. You are public service servants. You do not get paid for your services here. We have to manage a $71 million budget. The work is hard. CMH is complicated. So I want us to get in the habit of formally acknowledging people that have served on the board. And I intend to bring forward that next month. I submitted an email, and you should have got a handout of my director's report. I was told that Mr. Byrd has to leave for some appointments, so I'll be short-winded, which is hard for me. Okay. So I'm going to cover a couple of key items. First, I'm calling it Time to Thrive in 25. With the advent of our new year, I'm beginning the process of developing a 5-year strategic plan that will ensure input from a wide variety of stakeholders, including consumers, guardians, families, CMH staff and leadership, the CMH Board of Directors, the Lakeshore Regional entity, and Ottawa County Administrators and Commissioners. I intend in February to present a structure to walk us through a 5-year strategic plan development. the key themes of the strategic plan will have two fundamental kind of focuses with many subpoints. One is keeping community and community mental health, ensuring we have a benefit that transcends the Medicaid benefit. We are not just a Medicaid insurance plan. We have to start acting like that. We have to maintain community services that go beyond Medicaid and ensure active voice from stakeholders. The second major part of the strategic plan structure will be becoming a center of excellence in every way. And so some of the key goals, not all of them, kind of major themes I wanted to highlight. In keeping community mental health, it's providing services in addition to Medicaid, as I said. It's ensuring family, legal guardians, and person-served input until our strategic plan. It's leveraging community mental health of Ottawa County status as a county department to ensure collaboration with other departments and county resources. Maintaining community and community mental health in Ottawa County does include the county. And so I want to find ways to move towards the county, not away from the county, in terms of interdepartmental relationships like the VA, public health, jails, like we already do, maintaining those services, and leveraging county resources, including additional funding sources if able. So that's a major part of that. And there are many subpoints and goals related to all of these general things I'm saying. In terms of becoming a center of excellence, it's really developing a robust outcome measurement system, and we've begun the process of doing that, which you'll see in a moment. It's the continued use of best practices in the delivery of our services. We utilize over 11 different evidence-based practices of community mental health that the private sector are not required to use, from things like motivational interviewing or dialectic behavior therapy or parent psychosocial education or parent management training. We have a list of robust evidence-based practices that as a public system we must use, that we need to educate the board and the community that we're using them and the outcomes associated with them. So that is part of being a center of excellence. We need to develop a utilization management system that ensures consistency in determining amount, scope, and duration, the rates we pay people, fiscal stewardship, and tools that have validity and reliability to answer the question, how do we determine what's fair inside the person-centered planning process of the amount of services we authorize? To date, we don't have a tight system that does that. And so there isn't oftentimes a predictable way which we're trying to determine the different levels of care that to me would be where we want to be ultimately. We have a method, it works the way it works, but we need to improve it. So in February, I'll be outlining the structure, process, and desired goals of our strategic plan process and how we're going to ensure active stakeholder involvement in determining a 5-year strategic plan. Does that make sense? Okay. I'd like to now turn to the CMHOC Medicaid Deficit Reduction Plan. As you are aware, in November, we discovered, in a sense, that we had an anticipated Medicaid deficit that was unanticipated. The sources of that Medicaid deficit were a reduction in Medicaid and CCBHC expected revenue and over expenditures or unanticipated expenditures in 3 primary areas: autism services, specialized residential, and community living supports. So over the last 60 days, I have initiated or strengthened several key components, and I've listed 8 of them. There are far more than 8, and I intend to examine several at a time every month, but I thought I would highlight 8 of them for the public and the board's knowledge of how are we addressing the deficit. 1, we froze all CMHOC positions funded by Medicaid. However, I will release positions, unfreeze them, so to speak, vacant positions, if that position is determined vital for Medicaid service operation or generates additional revenue. Does it make sense to keep a position frozen if it can generate revenue or it's absolutely vital? I've put together a process within CMH that's it's still in its development. We've been utilizing, it's still improving, of identifying all of our vacant positions, a process of staff to request them to be, quote, unfrozen, and an analysis of the cost and benefit to do that. We have done that since the first time we learned of the unanticipated deficit that we had. The second thing I've put in place is a rate setting and request for services contract review. We now monthly review all of the potential contracts as a leadership group that come before the board for consideration. You'll notice in this month's package, we have 2 contracts, just 2, and none of them are new. They're renewals. That's probably the least amount of contracts this board has seen in the history of the CMH board. Some of that is the timing of where we're at in the fiscal year, but some of that is the work of this group saying we can hold off on this one. We need to determine due diligence on filling it, and really ensuring that we know the impact to all new contracts to our budget. So we put together this rate setting and request for service contract review. It also helps me do due diligence that all of the contractual steps are done. Because remember, I told this board, if I present a contract to this board that you vote no to, I have failed not to meet the terms and conditions of contracting. So we're reviewing those in a monthly meeting. And it's still developing. We're getting better at it. Critical conversations are happening, but that was put in place. We also established the Residential Utilization Management Committee and the creation of centralized residential services. As you know, since I arrived on the scene, 6 months as permanent, 2 other months as interim, I declared a residential services emergency in terms of understanding what we're paying residential providers, how we're authorizing those services, how we're dealing with changes in consumers' conditions when they need residential services, what tools do we have in place to both request residential services, authorize them, and determine its impact on the budget. So we've established a residential utilization management committee, and we're reviewing all of those issues. And you'll hear later that I'm actually bringing in some contractual help to help us develop very specific evidence-based tools to determine residential services eligibility and placement. So you can read some of the subpoints that we're doing in there. We've also created the Community Living Supports Utilization Management Initiative. Oh, it's a mouthful. We have to review all of the CLS rate structures we have there, what we're paying providers, the hourly payments, the lack of providers in general. It doesn't do any good to authorize CLS services if you don't have people to provide them. And if you're in a self-D arrangement, you know exactly what I'm talking about. So we're looking at the CLS provider network. We're going to have to gain input from families and other folks on what's needed. And we're looking at how we're specifically authorizing community living supports, amount, scope, and duration for those. And we have guidelines now, but we have to strengthen them, make them public, and have organizational monthly oversight on that. And we're in the beginning stages of beginning this initiative. Well, we're kind of 30 days in. We also, system-wide, have to strengthen our utilization management tool development and guidelines as a whole. And it's related to the aforementioned issues that I just went through. But overall, our utilization management system at CMHOC has to be strengthened considerably, and we're doing that. One of the ways we're doing that, you approved several months ago, the implementation of a new EMR / kind of like MCO electronic system. We call it Auto. We had a name for it. We had a contest. The second choice was Bob. But, you know, I didn't want to say, well, Bob went down again or Bob's not working. So we ended up with Auto. And implementing a new EMR and a fiscal management system, managed care, utilization management platform, we are estimating that we're going to be able to recoup hundreds of thousands of dollars in revenue that have been left off the table because our current EMR requires us to manually do thousands of double checks to see if they're eligible for additional supplemental Medicaid payments through the CCBHC program and others. So usually when you're implementing a new EMR, it's stressful for an organization. It's stressful, but this is unifying CMH. Our IT, finance, clinical staff are learning a common language and a common system. We'll be fully integrated with the rest of the CMH system, computer systems, the states and the regions. And it's my estimation that implementation of auto will be one of the major drivers in determining utilization management and capturing uncaptured revenue. And even though the full implementation of this won't happen until June, we're already having the conversations of what we need to put in the system so that we're fundamentally tracking authorizations, new services coming in, cost of care, all of these elements that have atrophied through the years due to kind of reductions in some of our staff and our system being so antiquated. I'm telling you, Amy here has got staff that have to literally get one report, run the whole thing, and then individually go through each item and attach like modifiers so that we get different forms of like manually. Auto does it automatically. You go boop, it does it for you. You just double check it. So that is going to be a major help, believe it or not, in addressing the Medicaid deficit issue. On the both CCBHC Medicaid side through the loss of revenue and recapturing that, and ensuring that we truly have accurate pictures of cost of care. So I'm excited about that. It is a stressful process. Staff have been very positive. PCE, who's the company that's implementing this with, said that it's a joy to work with their staff. We get continuous compliments from them that we meet all of our deadlines that they give us in terms of the information for the transition, that staff are prompt, that they're eager, that there's no negativity at all in this when we're meeting with, and that shines highly on the CMH staff that's been asked to do this. One of the other things we're doing is a CCBHC expenditure and revenue analysis. We're in the process of analyzing all of our CCBHC expenditures. If you remember, that's one of our funding sources. We're able to allocate a whole bunch of costs to that funding source. And we're in the process now of making sure we have everything associated with CCBHC costed in the right bucket, per se. And we're generating extra revenue by delivering CCBHC services. And so we're really looking at all of our processes on how we generate extra revenue, the expenditures costed to it. And we're actually due to give us the state a report in March anyways and how we're doing it. So we'll have stuff in February and March and how we're doing on that. The goal is to capture as much Medicaid, CCBHC, supplemental revenue as we can. It's my belief we're leaving money on the table right now. And when you'll see with some of the financial reports that we review later today, some of our estimates on CCBHC revenue are off because of some of the issues I've already discussed. And so we're focusing on it. I'm also focusing on, obviously, the Medicaid Equity Initiative. I've begun the process of developing the Medicaid Funding Equity Action Plan to ensure that Ottawa County is receiving the Medicaid funding required to meet the Medicaid service requirements. I will present an action plan in March that will have legislative, community, stakeholder, and CMH advocacy goals and objectives in plan. March is the time, and talking to some of the legislators, they're like, don't come to me until it's March. If you come to me right now, we're still trying to figure out what's what up there. And so my action plan will have components this board and the community can advocate for more Medicaid funding for Ottawa County. And I'll be working with the Lakeshore Regional entity as well. Lakeshore Regional entity is not the enemy in this, they're our partner in this. We have to help the Lakeshore Regional entity advocate and prove that we need more Medicaid in Ottawa County and the region. I intend to do that. We'll have an action plan developed for your review by the, you'll get it before then, but by the March board meeting. And then I want to say that I had the pleasure of meeting with all of our support coordinators this week to review the core principles of supports coordination. It was a pleasure to meet with all of them. I stress that supports coordination is the core service in the IDDD division, and that frequent contact and relationships with consumers or clients, guardians, or primary caregivers is the primary task of the support coordinator. We have to have a robust strengthening of the frequency that we're interacting, sports coordinators are interacting with their clients and their consumers and guardians. And frankly, they have to have something to coordinate. There's not a lot of services to coordinate that are not in the same level of lack of availability. So when a support coordinator is trying to find things like respite or, I don't know, CLS, and we don't have the infrastructure to coordinate, I asked them, what are you coordinating? They said, we're putting out fires. And we need to change that, because if supports coordination has to be the core of that division, or it doesn't make sense for us to directly operate anything. So I intend to continue to work with that group and that division on developing the core principles and requirements of face-to-face contacts, and make sure that they have the resources available to meet the needs of the people that they are serving and have something to coordinate. At that meeting, they all echoed, we need guardianship training. So I kind of knew what Mr. Rockman was saying, so I preemptively put in my report that we have to create a guardianship training initiative. And so we'll work on that, and I will ask key members of the community to join me on that. But the support coordinators say, yes, it'd be nice to know the role and function of the guardian, how to maximize that, how we're educating. Now, is that primarily CMH's responsibility? No, but we must do it. We must do it. So I'll be looking for strategies to develop a guardianship orientation and training initiative that we use. And what a perfect use of millage. So look to see that coming up. Finally, yes.
Michael, if we could interrupt us.
Yeah, please do.
You've presented so much information.
Want to take a
to this
break and go
point.
through it? Yeah.
It's difficult to remember it all.
Yeah.
But while this is fresh in our minds, is it not an allowable Medicaid expense to support families of consumers?
Correct.
So that is a legit, we're not doing anything that's not legitimate
Correct.
in that effort. Yeah.
Yeah.
But
But
perhaps
it's about strengthening, that whole enterprise.
Yeah, Michael, one other question.
Yeah.
What is the caseload size, the average caseload
Yeah.
size?
So one of the things we did is we increased the number of support coordinators by combining them. Our ideal caseload size now is 35. It was over 50. So we've made an effort to reduce the size of the caseload. In fact, one of the frozen positions that I unfroze yesterday, I haven't told anybody yet, is one of the vacant support coordinator positions. And we have to make sure their role and function is clearly defined so we get the best amount. When you look at national literature on this, you get over 30, 35 people. You're putting out fires of 10% of your population, then you ignore the rest. So we're really, in my belief, really there. A lot of CMHs have 50 and some of them have 75. I'll leave the company nameless, as a consultant, I did a review on support coordinator caseload for a group in Kent County, and their caseload was 100. You can't even remember people's names. It is a caseload size matters. So we put the resources in, and remember, when we were adding positions, we were projecting actually a Medicaid surplus for this year. So we were adding stuff going, yeah. And then like, uh-oh. And so now we have to stop. But it doesn't mean, it's like you still got 60-something million dollars in Medicaid. It's how you spend it. And to me, supports coordination is a core thing. If we don't get that right, the rest of that and that division starts to break down, in my belief system. So caseload matters. I had two other items, but I'm willing to take other questions related to the exhaustive things I threw at you quickly. Or I could finish the two and then open it up for additional questions. It's your leisure. Okay, I'll keep going. One of the things we've done is a new core data dashboard development. In your packet, I have some screenshots of a couple of things, I'm about to show you. But we actually have a dashboard that you'll get the link and others will be able to access soon on a monthly basis to see some core data elements. Okay. The first one, can I see a computer? I can't see that far without. Yeah. So the first one we're looking at is consumers served by population. And you'll be able to see on average, we serve a little bit more than 2,000 people a month, and you can sort it. So if my assistant can hit like the adult MI button over there, it will kind of show you that. Now, if you hit the middle tab there, program type, go down. Yeah, hit that one. You'll be able to see by population and then by age, how many people we're serving. And definition of services is they're open consumer and they've received at least one service element from us, right? You can see kind of like the trending of where we're at based on population. And this is a good dashboard to answer the question over time, how many people are we serving, right? There's another dashboard, which I'll take you to, where you'll see every month that will break it down by population, by age. And those are some of the screenshots that are in your packet. It's the, I can't see, let me. Not on this version. Let me see. That's the same one. Yeah, well, I can't pull it up, but you have two screenshots on here. I don't know if the link went dead on our dashboard. That's not good.
I got the link.
Yeah, but it's not, the group of reports are not sitting there. They were there last night. So what you'll see in my report is a couple of screenshots, and it's in the packet. You won't be able to see it on the TV. I'll make sure the public has it in there. One, every month you'll get the previous month's data on crisis and access. So you'll get how many people accessed us, and we had our navigators work with them, and what happened to them. So their first metric is what happens when you come into CMH and you determine for eligibility, and of those, how many were accepted and how many went to different type of referral sources? Like they weren't eligible for us, but we sent them to, like, they had to go to a homeless shelter, which is a very small portion, or they went into other type of services and the type of contact we had. So you'll be able to see monthly kind of what happens at the front door before they're accepted. The other report you'll see every month is the amount of crisis contacts we have and what happened to them. Those that came to us in crisis, how many of them went to the hospital? How many of them went to a crisis residential program? How many people were diverted to an outpatient or another form of help or partial hospitalization? So in December, we had 89 contacts, and we diverted over 70% of those away from hospitalization, meaning they all had the potential to go into a psychiatric inpatient hospitalization. And over 70% of those were diverted to other programs like crisis residential or other stabilization services. But every month, we'll be able to keep track the number of inpatient admissions and what happens to people when they come to CMH in crisis. And I think that's a vital statistic that we look at every single month. And I'll make sure we have the appropriate links and you can see this in the future. But and we also can break it down by age group, adult versus child. Like we had 30 people going to the hospital last month, 10 were children, 20 were adults. Average length of stay goes anywhere between 3 to 10 days, just depending on the situation. And the average cost is between $1,000 and $1,200 a day. Plus, we don't really want to hospitalize people that don't need to be hospitalized. And it gives us a way of, is the other programs that we have to divert from hospitalization working? So we'll have to develop a metric like if hospitalizations are more than 30% of those seeking crisis, is there something going wrong with our diversion processes? So we'll be able to use this to develop our own benchmarks of excellence. Like we want to have a goal of only 20% of folks seeking a crisis from us with a psychiatric crisis have to go to the hospital. So once we have enough data, we'll be able to set our own thresholds related to the appropriate utilization and deferral of crisis contacts. But this gives you a key element. Last one, which is something that most people want to know, is of those that were found eligible for, like how many people that seeked our eligibility assessment were actually found eligible by percentage and where do they go? This means they went through the original screening process, like, no, you didn't, this is not the chiropractor, this is CMH, a basic screening, and they actually went through a formal eligibility process for access. And of that, in December, we had 44 of such assessments. 84% of the folks were found eligible for CMH services and 16 were referred out. And we're able to show you in another report where they went. They just weren't dismissed. They were referred out somewhere. And we have that by population. We have that by autism, family services, adult services, and IDD. And in December, this might be a record. I'm double checking the numbers because I can't believe it. We didn't have any folks seeking services from developmental disability, new clients. We had 0 in December. It's usually like 5, 6, sometimes 10. I know in November we had 10 seek it and 10 got approved. But you'll be able to see both quarterly, annually, and monthly how many people sought services, how many people were found eligible, how many people were introduced into services. And this will be a key dashboard that will eventually be on our website for the public to see all the time, because I often hear you can't get into CMH. And I'm not saying that's not true, but I want to make sure we have a dashboard that demonstrates that we're tracking that. I want to know what happens to people when they get into services and who's not eligible. Where did they go? What happened to them? So a couple of these core metrics are being developed. I apologize, I couldn't figure out the link today on that. We just put it there yesterday at 4 o'clock. So it probably needed to be refreshed or something. So just want to let you know I'm making good on what we said, that we have to develop ongoing dashboards that we're reviewing. This will be a set of 3. You're going to end up like 15 of these indicators within the next couple of months. We're developing a fiscal services dashboard and a dashboard that has other elements to this, to build on the existing ones we have that people can see and review every month. And that is the conclusion of my report. I'll take any question related to report or anything else you'd like to know.
Are these because of Otto?
No, these
Oh.
are because of IT or staff or staff.
Okay, well, I like it. Thank you. So I thought if that's Otto, that's cool.
Yeah, Otto will make this easier.
Okay.
The folks have literally had to take data sets, put them in different systems and recalculate the information for me. Because I'm kind of stubborn. I'm like, I need it now. They're like, but Otto. I'm like, I can't wait till June.
Mhm.
But staff worked really hard
Yeah.
we had all this data in our system, in our avatar system, which I call Atari at this point. But it's hard to get to the data. And a lot of the folks that we had that worked here that knew how to do it all left. So that's why I said learning a new system has been very, very unifying,
Sure.
especially in IT.
Sure.
But they were so proud yesterday at 4 o'clock. Tony, our IT director, came in. We got it ready for you. I'm like, well, good. Okay. Because county commissioners need to see this every month too. And I'll put it in a different format
Mm-hmm.
and the public needs to know. And this is just the beginning of outcome dashboards that people can see. Our management of the system has to be transparent.
So on that note, I want to do this to you and then please pass it on to your staff. Thank you so much for all of this, because this, from one ED to another CEO, there are so many things that you are flip-flopping every day, right? Staff, we got hundreds of people in our county that need supports. Thank you for that hard work on top of all of the research. Like, I watched all the emails come through about all the different board members over the years. That was a really big, big lift to expect of you, and I'm thankful for you to do that. I feel like it was unfair. So in midst of all of the super important stuff that people need, you guys did all of that. So thank you. I know I'm looking at you.
Yeah.
Thank you so much. And Dave and I went to their Christmas party back in December. And that was the first time really seeing all of you in one body. And there's a lot of them. And so we don't get to see that. And to your point a couple minutes ago about giving the thanks and the appreciation, I want you to know that that's genuine and it's true, because in the midst of everything that you guys have to do every day, you have to pull out 20 years of board memberships.
Right.
That's crazy. So thank you, thank you, thank you.
On a more granular level, and recognizing that I'm new to this process, are we following up on post-hospital discharge service connection?
Yes, we actually have an indicator to ensure that we have follow-up within 7 days of post-discharge.
Okay,
It's one of the states called MIMBUS indicators.
okay.
And we do very well as a CMH on that, the best in the region, with both inpatient recidivism rates, right? And follow-up aftercare. We're actually number one in our region.
Excellent.
Be happy to include that in our dashboard so you can see. We already have one.
That'd be nice.
Yep.
How are we going to get this information? You say, you want to inform the public and get the community, and how will you get this site out there? I mean, is this something that we can educate supports coordinators on?
Yeah.
So we get more parental involvement that says, hey, you can go to the website and follow what's happening.
Yeah.
Because it's all good and well, but if nobody has knowledge of it existing, it's not going to go anywhere.
Yeah, and so it's going to be a combination of methods. The county's just launching a new website. And so our website, we've had to kind of wait on how to change it.
Mhm.
And I know that staff are like, yeah, I want all kinds of stuff. And they're like, Michael, the website would be this big. I'm going to have to, in my Did You Know series, community series, let people know about core topics like access coming up and bring this information. We're going to have to reestablish and revitalize the Consumer Advisory Committee. And there are members in the audience that I need on it. And really to beef that up, but there needs to be a lot more of a campaign to send information out, an opportunity to talk to people face to face and not just check a website. I go to the website, I can't find half the crap, and I'm the CEO. So that's just saying, making it available, but we'll have to really look at how we're doing community education. And so I intend in my series to include certain elements of this. Hey, come learn about, right? But then have some expectation for the directors of the different divisions and staff to do their own community meetings. And we have community kind of education things that we do through customer service. But like Rosalie said earlier, we have to get better at, I'm still haven't finished, like recording and receive, people work or they actually take care of folks. They can't just drop everything and come to the Dr. Bashir's as whatever, right? So we have to have several methods of doing it. And that has to be part of a strategic plan. That's a major anchor in it.
Yeah.
Or you can't have community and community mental health if the community has no idea what community mental health does.
Right.
Doesn't really.
No, I appreciate that, because your meetings too that you do, I would love to attend,
Yeah.
but I have a special needs son.
I know. I do them on
And I can't even
Fridays.
go on a date with my husband, so let alone to get to a
Right.
meeting. It's difficult. So I know, right?
Husband, Dr. Bashir's.
Right.
Which one should I pick?
Right.
You
But
know,
that's true. And we will get better at it.
Yeah. I appreciate that.
And your next tutorial is February 7th, right?
Yes, and I'm going over access and I'll be using some of this data. You
And
know,
that's 12 to 2?
mhm. Yep. You know, worst day of the week, I know.
Friday.
So we'll look at it.
Sorry.
But it's kind of, it works. And yeah, we'll get those out there, but staff are working so hard. We're moving forward. There's a sense of like, we're going in a direction to solve some of these things. And so it's been easy to do.
Where's the location?
At James Street. Yep. Yep. In the formerly CMHOC boardroom. Maybe someday we'll be back there. Not on a Friday morning. We'll see. Other questions? Threw a lot at you. Obviously, you can contact me anytime. I work for you. And we will answer the question.
Just please pass on the gratitude.
I will.
The next item is a presentation. I'm not sure what that is.
There's nothing there.
Oh, okay. Then we go to old business.
Yeah, it's the ever elusive, do we want a finance subcommittee? I did hear from one board member to say, I'm interested in being on it once you have it. That was Chris. My thought is the original idea was to have a finance subcommittee, correct? To go through the financial aspects of the work so that all of you don't have to be drilling down all of the time. And so I have it on here under old business because we can either table it to see what happens at the county level this month and then address it next month, or see if you desire to still form a finance subcommittee, which then you'd have to appoint a chair and members. Because I already went over the structure of it like 3 months ago. I can bring that back in February if the board would like.
Unless someone has another view on that, why don't we take that under advisement? Anyone who has a desire of serving on a committee, a subcommittee such as that, let me know and I'll discuss it with Michael and we'll hopefully do something decisive one way or the other next month.
Michael, do you anticipate other committees in the future?
The only other one that I would want is a kind of like a program and quality type of committee to drill down on program development and quality benchmarks. That's the only other one that I had in mind in our structure. And we all decided, let's walk before we run and get one situated, and then we look at the other. You know, we already have a recipient rights subcommittee that the whole board is part of, you know, and the consumer advisory group will report to me, but I want them to have formal reports that I develop on their behalf to the board. So I'll have to come up with a plan to integrate that here, because I need that consumer advisory group, consumers and their families, to help with needs assessment and strategic planning. And so that's the only other group that kind of has a dotted line to you.
So that one is not made up of board members, is that what it?
Correct.
But these other two, program
Would be.
development, which was a great idea,
Yes.
have to be made up of board members.
Right.
If there's no other discussion on that, we do have, under new business, we had previously had the appointment of the new board chair, which was moved up. But that creates a situation where I am no longer able to serve as secretary. So we do have a position open for secretary on the board if anyone would like to make nominations for that.
What does the secretary do?
You wondered what the secretary does.
Sorry.
You wondered what the secretary does.
Oh, the secretary's most important job. You have to sign the minutes when they are approved. The secretary is also responsible for oversight of the Open Meetings Act, that we are in compliance with that, making sure that staff properly notices meetings that the board has, and that basically those administrative functions are taken care of by staff. So the secretary provides titular oversight, but the only real involvement is making sure the minutes are accurate and that they are signed once they are approved. But you're also a member of the executive committee. So if anyone would like to recommend someone or volunteer.
Can we nominate Peg? That's what you do, right?
You could,
Do I sense, Donna, you were volunteering?
No, Donna's not volunteering. I just don't have time right now for extras, but.
Well, we are required to have a secretary, so unless you'd like the board chair to appoint someone, this is your opportunity to rise to the surface.
I nominate Beth. She's here. It's not fair to Peg. But I would have.
Are there any other nominations? Are there any other nominations?
Is Beth okay with that?
If that's the duties and you feel I'm responsible to take that on, I wasn't even aware what the secretary did, to be quite frank, but I'm willing to learn it. So we need somebody.
Well, if you are willing to serve and there are no other nominations, then we will put your nomination to the vote. Do we have a roll call vote for that?
Wenzel? Yes. Savage? Davis?
Yes.
Verkleinians?
Yes.
Van Hoven?
Yes.
Ms. Brody?
Yes.
Bunce?
Yes.
Pernin?
Yes.
Bird?
Yes. Congratulations and thank you for
Thank you.
being willing to serve.
Don't tell Peg I said that.
Yeah, well. He's
Like she can't be hearing right now, but we'll get her used to us first.
Great. Now we'll move to the financial reports.
Okay, so we're presenting the statement of activities for year-to-date fiscal year 25, October 1 through December 31st, 2024. With the mental health fund, we are currently at an actual of 20.23% with our aggressive target of 10.61% at this point. So and for the millage fund, actuals at 33.2% with a target of 25% for that first quarter. Are there any specific questions? If you recall, we drew out the CCBHC funding dollars, so that's a little more apparent to see how that fits into our revenue lines. The total expenses are in the bolded black box is kind of our running total of where we are. We are projecting an overage, so we do have a pretty ambitious target schedule so that we are aware early within the first quarter. So being at 576,000 over budget for the first quarter, if you kind of translate that for the year, hopefully we can stay within that range and, have that transparent reporting to you early. So I don't know if there are any specific questions, but we're in a good position and working on some different reporting dashboard items to target some of the initiatives so that we can put a financial number to that and have more budgeted like variances. So we can, we're still working on that in fiscal. So more to come on the finance side, but there any questions or?
Looking at grants, what is the grant outlook for like the next 2 quarters? What's tailing out? What's coming in? Is the management, the time spent on management of those grants going to become more onerous if there's not enough grants coming in to kind of like handle that piece?
We have a pretty good grant structure right now. Actually, last year is when we took a hit on our grants. We lost $1 million in a CCBHC grant. Right now, pretty consistent. We've added grant support staff. So an administrative assistant under, is that the title? A grant assistant. So I think as far as things closing out, we have a few grants that roll over and are restarting now, so we're not really losing those revenues. We had a few carry forward dollars as well, so that's a positive in our favor. At this time of year in the first quarter, kind of plugging along business as usual. We are recosting for our CCBHC demonstration dollars. So there may be additional resources in our supplemental grant funding there as well. So from a grants perspective in general, that's in a healthy position. What was budgeted is what's expected and what's coming in. So we haven't taken hits on that.
Thanks.
So just one other question. So are you anticipating that we'll continue over budget at about the same rate in the following quarters then?
That's a tricky question. We readjusted how we are establishing our target numbers. So this is like the first time we've done that. Typically, and actually what will be presented to the Board of Commissioners is based on a quarterly look. So 25% would be your standard. But typically we reassessed our target based on 8 years of activity, accounts payable activity. And within the first quarter, we're typically at 10%, 10, 11%. So we're trying to demonstrate where we're at financially. There's goals to bring that in, but I do believe that, I think a healthy place to be in 4 quarters is, 4 times 576. That's kind of what I'm looking at as a measure. When we get to the end of the second quarter, reassess, our numbers good? Is our activity increasing even faster than budgeted or what we were anticipating? But
Yeah, and at least we won't be surprised this time.
exactly,
Okay.
right. One of the big things that happened is we processed 30% of our payables within the last 6 weeks of the fiscal year. So when you're only accounting for 25 in a whole quarter and you have 6 weeks of 30% of your activity, and when you had Medicaid surplus, it wasn't as apparent or critical to know. So
Right.
yeah.
Okay.
So are you including potential revenue from picking up auto in your projections going forward? Not yet.
I guess I don't.
Potential savings, potential revenue that could be generated because auto,
Efficiencies.
yeah,
I think that we are, Dr. Brashears has a plan of looking at all of that for,
it's not in there.
cost savings. And it's not in the assumptions. I don't know if you've shared that about the LRE, maybe there would be funding for that
Right.
to cover the expense of the implementation
Okay.
itself.
Sure.
So I know the question was asked.
But our assumptions of potential revenue increases due to efficiencies and the 7 points that I was talking about earlier haven't been put in our budgetary assumptions yet. I gotta have evidence that they're actually working before I make the assumption.
Right.
So looking at the 30% coming in the last 6 weeks of the fiscal year, is that from a rush to provide service at the end of that fiscal year to get that in that fiscal year? Or is that from delayed billing from the service providers that are providing the service?
It is actually kind of normal activity for us. What happens is you pay both September and October at the end because we have service activity happening until September 30th that has to be billed. We also have billing that's happening up to September 30th. So it like almost adds another month at the end. We had new contracts that were waiting on signatures that delayed a lot of our payables between May and July. We had new placements that really increased, we had, I don't know the numbers, but specialized residential placements increased significantly last year. Autism services increased. And a lot of those were new providers or had contract adjustments that we were waiting. We can't pay until the rates are signed and approved and the contract's ready to go. So we had delay. It was kind of a flurry of a lot of things, but it's typical activity. And one of the things that hadn't been considered in a quarterly review or a monthly 1/12 of your budget review is the fact that we're paying 2 months at the very end because everybody has to bill still for September. And then they have to get in all of the coordination of benefits. So all of the claims that our providers have out to insurances for payment first before they bill Medicaid have to all come in. And so it is a big rush in our provider network. We communicate that, we try to tighten that window, but we still have to pay those services. I can't help that Medicaid takes 8 weeks to pay a provider Medicare, before they can bill us for the remaining portion for Medicaid. So some of that, it's kind of all of those factors. And so I think in general, doing an exercise like this where we're not just considering 25% spent a quarter will help us long-term as well and adjust, be more in the moment.
All right, thanks.
Mhm.
Are GF funds listed separately or is that the other revenue?
Well, general fund, are you talking about county general fund versus?
For revenue, we have state GF funds. Is that a separate
The
account?
county, local funds are this county's general fund
Yeah.
contribution. And then maybe we could label that better.
General fund is in
General
the
fund is
revenue.
the state general fund.
It's there, though.
Oh, there it is. Oh, I'm sorry, I missed that. Yes.
Yep, it's right under
Okay.
autism.
So that's the state's number, and then the local funds is the county's general fund contribution.
Any other discussion on that? We can then move on to the LRE report,
Need to,
just for information.
the LRE is just for information. Yep, this is the combined summary, but I don't know if there needs to be
We
a
need to
vote for.
on
Yeah, in the December financial.
Seeking a motion to approve the financial report as presented.
Support.
Second.
And any further discussion? Can we do that by voice vote?
Roll call,
Okay, roll call.
because there's money in it.
Ms. Van Hoven?
Yes.
Wenzel? Yes. Mr. Davis?
Yes.
Ms. Rhodey?
Yes.
Mr. Savage?
Yeah.
Bunce?
Yes.
Mr. Kleinens?
Yes.
Mr. Kernan?
Yes.
Mr. Byrd?
Yes. Motion passes. For your LRE report, does anybody have any questions or discussion about that?
And again, this is just through November, so it's always a month behind what we're reporting, you know, for our activity to this board today, so.
Could I ask a related question? I'm just curious, where things landed. I think that Kent also had a deficit this last year, so I'm just curious kind of where things landed with the other, members of the LRE.
So we're still in the reconciliation process with the LRE, Lakeshore Regional, and for last year. But they ended with over $19 million deficit.
Okay.
In fact, they're still projecting that.
Hmm.
So the other partners, they were either had a flat, but like either came in right at flat or a little bit over or under, but really just Network 180 still has a substantial deficit. Now, remember, they have a $200 million budget.
Mhm.
They're half of the LRE revenue, but it's very important that that particular board is stable, has enough revenue, because it's half of the funding for the region. So I know they're working hard to resolve it, but it's a difficult situation for them.
Couple related questions. So then what did our total end up being, our deficit?
I think we're still determining that.
Okay.
I think, do you know when we finalize the?
I have, so we have all of our claim reporting due and our final report is on the 29th of January for claims. And we take that data and then go back to our general ledger. At that point, we've received all of our revenues. We just got some of our last payments. So the deficit, last I knew, or last I ran the reports, which was late November, was still like 5.3 million,
Okay.
but we have gotten significant revenues. I think it'll still be between 4 and 6
Okay.
million. I'm hoping more for 4, but I don't want to be optimistic, until we have the claims and the comparison data.
Okay.
But, we also have a reconciliation for CCBHC that happens after that could reduce some of that amount as well. So we'll have more, next month, we'll have more of those numbers more drawn together.
Okay. And you're probably looking at this, Dr. Rushiers, but it's interesting when you look at, you know, the size of ours and theirs, it kind of tracks fairly similarly. I mean, it's still a higher percentage for them than it is for us, but it's not that far off.
Right.
So I'm sure you'll look at this, but I think it'd be interesting to see like where their big deviations were. Are they the same as ours? You know, like,
Yeah.
are we seeing trends in autism and residential?
And in fact, I can answer some of that now. They have similar trends in the utilization of specialized residential, CLS, and autism. Autism being the big primary driver for them,
Okay.
and a huge increase in services. We've seen over a 200% increase in utilization in the last couple of years here. So the question becomes, what are your utilization management strategies, and are you doing those correctly? And then you can then defend the request for more revenue.
Mhm.
What happens to us within our region, in most regions, is there's a belief like, hey, you're managing well if you stay in your budget. like I've educated the board and anybody I can possibly find at any time, we get the same amount of money regardless of how many people we serve with traditional Medicaid. There's actually no incentive for a CMH to have new cases come in, besides you're obligated to do it. So what is the real expectation on increases in utilization that are planned? Does the revenue match? And the state claims they have a process and they group Milliman report, they do all this stuff. But I can't find anything that connects expected increases in utilization with proportional increases in revenue. And I'm re-reviewing our contract with the region and the state on Medicaid to say, gee, why do I sign a contract where they don't give me enough revenue to meet the obligations? And so we have to make sure we're doing everything appropriate from a utilization management point first before I can claim more revenue is needed. And that's why we're doing it in a stage approach, examining making sure we've tightened that down, and then demonstrating with data the absolutely need for more revenue to allow the Lakeshore Regional entity to advocate too. But Network 180 is in the same exact position when it relates to that. They have increased demand and not a proportional increase in revenue.
Yeah, and if you guys are seeing the same things, that should be really helpful to legislators.
Yeah, you get both of us together,
Mhm.
that's a lot of legislators.
Right.
You know, and I think there are many places in the state that have the same issue. There are some regions, though, one of them, that have a $40 million surplus. So something's not right with Medicaid funding equity, where they have $40 million and they're fighting the state because they want to be able to keep more than 7% of that. Because the state only allows you to keep up to 7% of the Medicaid savings in your internal service fund, which is the rainy day fund that will help pay for our last year's deficit, right? They got $40 million sitting there and they don't want to give it back to the state. And I'm going, I know where you can send it, 616, I'll give him my number. But the point is, clearly we need a methodology in the state that moves the money around in a way of expected utilization. Instead of like, you have a managed care contract, you did great, you stayed in your budget, that means you're good. Well, if we're supposed to cut expenditures proportionately to the amount of increase in demand, we'll have no money in 4 years. So that's the other piece of this, but we're doing it in a stage-wise approach of cleaning up RUM so we can defend the request for more revenue. Because I don't want to hear, well, you're not managing it right. You didn't manage it right. Maybe someone else should manage it. And that's sometimes Network 180's told that. And I'm going, there's not enough revenue. So yeah, it's a statewide, but a region-specific problem for us.
Okay, thank you.
Just, Michael, to clarify for some of our newer board members who may not be thoroughly cognizant of our funding stream, we get our Medicaid money based upon the number of Medicaid eligibles here in Ottawa County. And there are basically two big categories: the DABs, people who are disabled, aged, and blind and qualify for Medicaid, and TANF, people who are meet the financial qualifications for need for Medicaid services. The difficulty is the state can decide, as they are doing now, to tighten up on the allocation of TANF awards.
Right.
And remove people from the Medicaid rolls who either added through Medicaid expansion or through policy changes, which the legislature is now currently considering in terms of cutting the DHHS budget and reducing Medicaid expenditures and using that money to fund other needs such as repairing the roads that's been mentioned in public news reports. If they do that, and they reduce the number of people on Medicaid, that still doesn't affect the DABs who are there and are entitled to services on the basis of their disability. That's never going to go away. So hypothetically, if somehow or another DHHS reduces the number of Medicaid eligibles in Ottawa County because they're reducing TANF categories, we still have the same population to serve.
Correct.
And we still have the same needs to meet, but we'll have a lower allocation.
Correct, and that's exactly what's happened. And so, Chairman Byrd, there's no relationship between the amount of money we get per Medicaid eligibility and expected penetration rate into the Medicaid community, meaning this: we only serve about 4 to 5% of the Medicaid eligibles that come in. If that went to 6%, if you took basic mental health prevalence rates, anxiety disorders as high as 20%, right? If you took 10% of the Medicaid population in Ottawa County and they came to services, we'd be bankrupt in a month. So at the state level, there's no relationship with expected Medicaid penetration, how many people you're going to serve, and the rate. That's what fundamentally has to change. No one's going, gee, it's a pandemic and we have kids with depression and anxiety off the chart. I bet you they're going to serve more Medicaid people. So we make sure that rate reflects that. No relationship between expected number of people served on Medicaid to the rate we get. And I fundamentally are going to challenge that. So as TANFs go down, we get less money. Same benefit is still out there for folks. We need a benefit that assumes that at a reasonable rate that people will seek care from us. If not, there's no incentive for us to serve anybody new. In fact, we get hurt. You'll see in the contracts here some of the difference in rates when we do it, when a contractor do it. You'll see when I go into that. This just makes it issue. We either have unbelievable caseloads at CMH, which leads to other issues, or we get, credit for, you're averaging 200 new people a year. The rates don't reflect that. They just take the number of eligibles and some other variables. I call it the Kellogg's cornflake formula at the state. That doesn't include estimated prevalence rates of those with mental illness, IDD, autism coming to you. What's expected based on what we're seeing out there. National data, 1 in whatever people of autism. Our rates don't reflect that. They're assuming they're not going to come to us. That's to me easy to get families to advocate once we get the so we know this information, but your public mental health system is not funded to serve even basic agreed upon prevalence rates of these disorders in your community. And Ottawa gets punished because they think you have less Medicaid DAB people versus TANF. I'm sorry, the Medicaid provider manual doesn't delineate between those. It's the same service array for whatever type of, not to mention Medicaid Healthy Michigan, which we haven't talked about. That's another part of it. So we got work to do, but luckily it's something that makes sense. We'll be able to get a message to deal with this Medicaid funding issue. But when you have one region that's 40 million in surplus and another that doesn't have any money, something's wrong. The Medicaid benefit's the same throughout the state. Shouldn't matter where you live. Should be portable throughout the state. You got members in this audience, Tom. They go to a different county, they get more services than if they're here. Why? Because they have 3 times more Medicaid. That ain't right. We got to fix it.
Okay, any other comments about the LRE? If not, we'll move on to your service contracts, Michael.
We have 2. One of the results of our committee, right? One's an amendment to an existing case management contract that primarily deals with folks that have mental illness served out of the county. And it's to provide case management and treatment planning. And there's like a rate increase. This particular case management contract we have for Ottawa County, it's when we use it, we end up paying, the budget amounts around $37,000. But you look at 2 columns I've added to these reports. One says estimated annual utilization. We're assuming it's about 15 people served at, look at the hourly rate. That includes indirect time thrown into it, paperwork, stuff. That's how you have to cost it. And then I'm offering a new category. called directly operated cost. If we were to do it, as of the information today that we estimated it cost us about $446 an hour to do it. So what's the difference? One gets paid for the direct service only, and our rate includes every other aspect of indirect care, treatment planning, meetings, all kinds of stuff people have to go to in there. But it gives us a first snap at how do we get our directly operated costs down? Well, you either lower the expenditures of that, which you're not going to decrease salaries to do, or you decrease the amount of resources in that department, you cut it, or you increase productivity, the expectations of case management units face-to-face you're doing. So remember, we were talking earlier in my report that we need a fundamental way of examining our productivity system, what our expectations are. And we were talking about supports coordination in that example, like how many times you're actually going out. Because when we're doing our costing analysis, it really is not totally, but heavily dependent on the amount of face-to-face work you're doing with folks. And so you'll start seeing that column and that, and you should have sticker shock of the difference for some of the reasons of when we directly operated or not. And we're doing an analysis to determine how we determine those costs and ways that we can get it down. So if you were reading, yeah, only 2 contracts, but that column should have stood out to you. Like, huh? But this is a contract that's very seldomly used that we need in place just in case for our out-of-county placements. So we don't have to have our staff drive out to wherever to do the service. Same thing for PT Solutions, providing PT, OT support for our folks with IDD. You could see that it's a very small budgeted amount because it's adding another person to the roster to do the work. And we have an estimated utilization of 27 clients in the past year at around $74 an hour. Our directly operated staff around $98.50. So anytime you get those 2 comparisons, but it's my belief that our OT-PT speech and behavioral infrastructure is underdeveloped. We don't have enough of them to provide, to me, the appropriate level of service with OT-PT speech. We're also in a Medicaid deficit. So it's not like I can just post positions and say, yeah, let's bring in 10 more, unless I know that we have the finances to do it. So this small increase in this contract is helping us deal with the need for more additional services in those arrangements. But with a group of folks that works closely with us already, without me having to add staff to do it, and you can see it's a very minor. So it's an amendment of an existing contract as well. You'll notice there are no new contracts on this list. And I'll open up questions. Okay.
Anyone have any questions about the 2 proposals? If not, we will entertain a motion to approve them as presented.
So moved. Support.
Any further discussion? And this would be roll call.
Mr. Savage? Ms. Wenzel?
Yes.
Mr. Davis?
Yes.
Ms. Rhodey?
Yes.
Kleinens?
Yes.
Sorry.
Oh, which one?
Mr. Erby, sorry about that. Ms. Van Hoven? Ms. Bunce?
Yes.
Vernon?
Yes.
The Bird?
Yes. All right. Any general information, comments, or meetings attended by anyone?
I'll just share what Dr. Brashear said earlier. Next week, Tuesday night, January 28, I'm having our annual parent town hall, and it's on housing. As I said a few minutes ago, it's a very hot topic for families like a lot of us up here. And we have 4 different organizations presenting what their organization is like, whether it's Gracious Grounds or Brother Sister Homes. So those EDs are presenting. We got 90 to 100 families coming. I asked Dr. Brashears to be present. big picture questions that people might have, especially the funding and all those things. And, just talking about that whole Medicaid eligible, I can tell you of the hundreds of families that we serve at Compart, that every one of those are Medicaid eligible people. And I would tell you that probably only a very few of them get services. And so even if I just sent my families over, it would overload the system of support, right? So I invite anybody, really, you may come and listen and be a part of it. I'm excited. Ben's Hope is thinking about coming. She had complication with the date, so she still might come, but I'm excited to hear the plans of Gracious Grounds and what they're doing. Agora Flats, it's a new housing ministry happening in Holland, and so we're going to hear from them, as well as there's one more. Now I'm going to bother me. I can't. Oh, Harmony Communities as well, right? So I'm excited, but it's truly open to anyone. Come and listen and just hear what parents are finding out and feeling and experiencing. And then if Dr. Brashears can make it, it's all right. I understand. No, it's okay. But that's what's coming up on January 28th at Compassionate Heart, 6 to 8 p.m. Love for you to come.
Can I ask you a question on that?
Sure.
Are you gonna by any chance be recording it, even just audio recording it?
I
so we
will,
can hear
I
it?
will see if we can do that. I know we're a little bit different in terms of what we have the capacity to do, but we just had a whole new system put in, so I'll see if we can do that for you.
Okay, thank you.
Anyone else have anything to share? There is a state association conference coming up. Has anyone on the board registered to go to that?
Mm-mm.
If you do have the time to do it, it is a worthwhile educational experience to meet with other board members from around the state. Now, in addition to the topics that are presented, you can, you've probably all received that information from the association. And to the extent that you have an interest in doing that, I'd certainly encourage you to do that.
We'll send the information back out.
Great. It's not too late to register.
Nope.
And that's in scenic downtown Kalamazoo. Okay, any other comments? If not, we will open the floor for public comments again. Again, please state your name and your affiliation with the county in terms of residency.
Hello, Krista Mason. I'm with Benjamin's Hope. I'm resident of Ottawa County. I want to actually bring notice to something that I think we should celebrate. You may be aware that Peg Driesinga, I know she's going to really be mad at me for doing this. Peg has faithfully served in a variety of roles at Harbor House Ministries for 20 years now, and for the last number of years as the executive director, and is making a decision to move on from her position. I want to speak as a director of Benjamin's Hope, and I would say this on behalf of others. She's collaborative, supportive. I've seen Peg put in days that are 16 hours long on a regular basis. She served her families faithfully. I can't think of a better example of a public servant in our community. I will miss her in her role, but she's still going to be available to all of us. But I just really wanted to take this moment to honor her service of many years.
Thank you.
Not allowing her to leave, so.
I thank you for all those kind words. And I don't know if I would live up to all that, but I do want to let you know that Harbor House has brought on our new executive director will be starting on Monday. And so I will be bringing her to introduce to all of you, because it is, as you guys know, this is a system that takes a lot of learning and navigating, and it changes constantly. So I plan to stay on for a number of months to help this new director get her feet under her. But also, I just want to thank you as being a part of this system. We often talk about what doesn't work, but imagine where families would be without it. And so I applaud all of you in your dedication to improving the system, and I think we have to constantly do that. It is easy to get lost in numbers and policies and benchmarks, but please remember at the end of all of those are human beings who are not all size fits, one size fits all, that have individual needs that change and ebb and flow just as they do for all of us. and the costs associated with those changes also ebb and flow. And so as you've heard Dr. Bashir's and you've heard Krista and myself and other providers, specialized residential is really in a crisis situation. But specialized residential is specialized for a reason. The care is fairly complex and desperately needed. And I will say too, as sort of a storefront, to some degree, families stop in all the time. It's families that we could serve, families that would not be appropriate for us to serve, but they just don't know where to get information. So Don, I applaud that event. I know we've done events as well, and I think the more education we can get out there, the better, as people learn the system and what's available, but also as communities come together and collaborate and work with you. I don't think it's just an Ottawa County a problem. We all serve together. And so thank you for my time with you. I'm not going far away, but I appreciate for all of you and all of your work. Dr. Bashir's, of course, worked with you before, working with you now, and all of your advocacy for the men and women that we serve and the men and women served by CMH in general. So thank you.
Thank you. Congratulations.
Thank you, Peg.
Anyone else wish to speak? No one, oh, yes. Rosalie.
Hi, Rosalie Austin, City of Holland. The website, there's been a lot of work, not only on CMH website, but the county website, but to link them two together. But can your presentation be in the minutes?
Yep.
And it's hard to access the minutes or the packet.
Yep.
And yeah, so that's exciting. And I'm just so hopeful and I'm grateful that you are here to give the community the hope. It's inspiring and there's so much work to be done, and I'm glad that everyone's willing to be partners and collaborate and listen and respect each other's opinions and differences of opinion. And the CHAM conference, it costs $490, but families also, it's a learning opportunity for them too, but how can we afford to go and pay that? There's 2 scholarships available lifetime for family members. I've applied for it. My dear friend Kira applied for it. We were declined, denied. So we pay dues for advocacy to belong there. Why is this so difficult to access a scholarship? Or families don't know that they're invited to learn too. And the MIMBIS, kind of the data, Michigan Mission-Based Performance Indicators, that used to be like a quarterly report when Rich was here. And yeah, I think there's more, but enough for now. Thanks.
Anyone else wish to comment? Michael, do we offer scholarships for any of Ottawa County family members or consumers to go?
Not that I'm aware of, but I'll look into it.
Mhm.
I was going to ask that same thing, and then maybe just to piggyback on what Christian said a while ago, is that a grant that we could get somehow that facilitates scholarship support? I have no idea, but
I think I'll work with the director of the Board Association to make more scholarships available.
gotcha.
The Board Association collects lots of dues. Scholarship equity now. Arranged.
Okay, well, if there's no further business, we will adjourn the meeting. Thank you all for coming.